most of you will be familiar with the massive problem that we have in our Australian Aboriginal population. Before going any further, I would just like to acknowledge the Aboriginal people, many who've actually been involved in this research over the 10 or more years, both as researchers and community members, and also acknowledge all of my many collaborators, of whom there's probably several hundred collaborators who have been involved in some of the projects I'll be talking about. But all of these projects really focus on this particular issue, that even in this day and age there's still a massive life expectancy gap, a massive burden of disease difference, and many of the contributors to this gap are things that are basically preventable. So we just heard from Rod, cardiovascular disease, mental and substance use disorders, injuries, respiratory diseases, cancer. And so I'm just going to talk about two of our projects, and they sort of illustrate different things. IHOPE, I didn't make up the acronym. IHOPE was originally a 3-year NHMRC funded project, but IHOPE 10 years later is still going. We keep updating the data set. There have been, I think, 6 different PhDs that have come out of IHOPE, as well as many scientific papers. Got 2 PhD students still working on it. It's covered a huge range of areas. I'm only going to talk about 3 areas, and I call it the most basic example of data linkage that there could possibly be, knowing that it started 10 years ago, but it's been an enormously productive exercise. So I'll talk about 3 very different areas from within IHOPE. And then Seeding Success, a much more recent study, which is, I think, around 4 years old now, and it's the one that I refer to as extreme data linkage because it involves 13 different data sets. We have a new project that actually has 26 data sets, which is now outstripping Seeding Success. But I'll just present one bit of work from Seeding Success, which looks at maternal age at childbirth and the subsequent developmental vulnerability of the child. So IHOPE was a pretty simple sort of study. It was about Indigenous health inequalities. What are the gaps in health outcomes? What are the gaps in treatment and access? And in particular, how can we unpack what is contributing to these gaps? Because as Rod mentioned, how do you actually unpack Aboriginality, socioeconomic status, and in our case in particular, geography? In Australia we have a very sort of unique geography where people are clustered around the coast. Only a few people live in the centre of the country in very sort of sparse populations. In some cases there are major regional centres, but really those people have very different geographic access to services. And of course Aboriginal people are more likely to live in those regional and remote areas. These are some of the things we've actually looked at in IHOPE, and you can see there are an incredibly broad range of topics. But I'll focus first on just what the data is, and as I say, it's the simplest possible data linkage. It's the entire population of this one state, New South Wales. It's every hospital record that those people have from basically July 2000 onwards. And it's what we call internally linked. So for one person, you can actually look at each of that person's hospital records over the period. And then it's also linked to whether or not they've died and the cause of death. I think this slide is slightly out of date because we keep getting updated every year. But we have, around 7.5 million people, more than 33 million records in the data set. So looking first at heart disease, which is really the biggest one, it is the biggest contributor to the mortality gap between Aboriginal and non-Aboriginal people. This particular project was focusing very much on hospital care and care for people who've had a heart attack, an acute myocardial infarction. And just very basically, you can see there are very big differences between the Aboriginal people who have an AMI and are admitted to hospital and the non-Aboriginal people. I guess the big things are Aboriginal people are 10 years younger when they have their first AMI. They're more than half are current smokers compared to only a quarter of the non-Indigenous who have an AMI. Much lower rates of private health insurance amongst Aboriginal people, much more likely to live in the most disadvantaged areas, and much less likely to be admitted to a major city hospital or to a hospital with specialist cardiac facilities. So you can see that all of these things are going to be together contributing to the inequalities that we see in death rates from AMI. But what we were particularly interested in here was trying to unpack those. And I'll just very briefly talk about multi-level modelling. Many of you will know what this is, but it could be useful for some of you because many of the slides I'll present will actually be using these techniques. And it's actually a technique that arose from educational research, which is why I think many of the people here will be familiar with it. It models data that are clustered. For example, people who live in the same neighbourhood go to the same school or in the same classroom, or in my case, go to the same hospital or to the same general practice, for example. And the underlying issue is that people who are individuals within these clusters are more similar to the people within their own cluster than to other clusters because they share exposures which often are not measured. And this clustering can impact both on the standard errors and the parameter estimates of your models. But it's a particularly important issue, this clustering, for Indigenous health research because of the geographic difference between Indigenous and non-Indigenous people. You've got your Aboriginal people living in rural areas with access to different services. How is it different? This is a standard this is just a sort of example. Standard single-level regression model just fits an average association. This case is just time. We sort of time to get to hospital versus distance from hospital, this example could be. While with the multi-level regression model, there's really sort of two different approaches that you can use, one or both. And with a random intercept, it just fits an association, in this case between, just within each individual geographic area, and allows the outcome to vary between the areas. You can also have both a random intercept and a random slope, which goes further and allows the strength of the association, not just the level, to vary among areas. So this project looked at revascularisation following acute myocardial infarction. So revascularisation is where you have a stent inserted, or you have a balloon inserted, or you might have a coronary artery bypass graft. It was known before we started this work that Aboriginal people were much less likely than non-Aboriginal to actually have a revascularisation after their heart attack. And so very simply, just adjusting for age, sex, year of admission and the type of AMI that they had, so this is STEMI versus non-STEMI AMI for those who know about this, quite a big difference in the likelihood of having the revascularisation procedure. So the Aboriginal person about almost 40% less likely to have that procedure, which seems a sort of amazingly large and inexplicable inequality given the known value of this procedure for these patients. But using that multi-level modelling approach, we can actually put in what we call a random effect for the hospital of admission. So we can take into account the fact that Aboriginal people get admitted to different hospitals. They get admitted to smaller hospitals and rural and regional hospitals. Once we take that into account, we actually sort of account for about half of that disparity. So half of it really relates to the hospital that you get admitted to, rather than simply the fact that you're an Aboriginal person. And this is obviously a good finding in terms of that institutional racism type of issue. If you're an Aboriginal person or a non-Aboriginal person who fronts up at the same hospital, you are getting treated in much the same way. It's just that you don't go to the same hospitals. But there's more to it than that. And for example, we can look at the comorbidity burden at admission for the Aboriginal and non-Aboriginal people. And what you can see from this plot is that Aboriginal people have much higher rates of many of the major comorbidities, things like COPD, diabetes, renal failure, and so on. And so once you actually account for those also in our models, we can see that effect estimate sort of moving back to the null. So the comorbidities also play a big role. That's an interesting finding, though, because when you talk to clinicians, they say that, in fact, people with comorbidities are often those who are going to benefit the most from having the revascularisation procedure. But there is a reluctance among clinicians sometimes to do more invasive procedures on people who may be at high risk. So this has been an interesting discussion point with the clinical community. So we've unpacked the gap a bit more. Finally, we can add in a couple of other things, so substance use and also private health insurance. And then we've basically sort of unpacked the gap completely. You know, as Rod says, exactly identifying the individual and unique contributions of all of these things we can't do, but we can at least say, well, hospitals are having some impact, but probably the things that are most important are the rate of comorbidities, substance use and SES, rather than the idea that Aboriginal people are being sort of treated in a racist fashion when they arrive at hospitals. It's sort of good news. And we've done a lot of work in AMI. I've heard people here asking about how does the work influence policy. The sort of multiple studies we've had in AMI, we've sort of tried to synthesise it down into sort of simple messages. This young age at first heart attack. I mean, really much of this is about prevention and early management of heart disease. The issue with revascularisation that I just presented. We really need to get better facilities at some of those rural and regional hospitals. And in fact, following this work, there's been a rollout of 24/7 cath labs to many rural and regional hospitals across Australia. It may have happened without our work, of course, but we'd like to think that this work has helped to contribute to an impetus to do that. And we have also looked at mortality following AMI. I didn't present that here, but it's what that work is showing is that the sort of follow-up care, the continuity of care, the secondary prevention following AMI is just not happening for Aboriginal people. But moving on, completely different area, road traffic injury. Was already known that Aboriginal people had higher rates of hospitalisation and death from road traffic injury before our work. But we, again, took this sort of unpacking it approach. So these are just incident rate ratios for hospitalisation for road traffic injury, just adjusted for age and sex. And you'll see that for small vehicle injury, which is basically cars, pedestrian injuries and bicycle injuries, Aboriginal people do have higher rates, while motorcycle the same as for non-Aboriginal people. But this is not taking into account geography. This is just statewide data. If we do our multi-level modelling magic and actually adjust for the area where people live as well, we actually find quite a different picture going on. And so the road transport injuries just move back to no difference. So once you adjust for the statistical local area where people live, Aboriginal people and non-Aboriginal people equally likely to have a car crash, basically. But pedestrian looks quite different. Aboriginal people, regardless of where they live, have almost twice the rate of hospitalisation for pedestrian injury. They also have a 20% higher rate of bicycle injury hospitalisations. But here, one of the few reverse inequalities you'll ever see. They actually have a lower rate of hospitalisation for motorcycles. These caterpillar plots show all the different statistical local areas ranked. And again, you sort of see the same picture, that in almost all areas, pedestrian injuries, in most areas, bicycle injuries are higher amongst Aboriginal people. Nobody knew this before, and it has actually, we then went on to actually try to plot some of these areas with really high rates. For example, this is pedestrian injury, and you can see there's certain very evident hotspots, and we have done some, worked with local communities and local councils to try to unpack what's going on here. Don't have time to talk about it, but a lot of it is to do with people not having access to public transport, going into these regional centres, sometimes alcohol's involved, and then walking home, and unfortunately having a pedestrian accident. So provision of sort of after-hours buses and so on is one of the interventions that helps there. So all that to say, motor vehicle accidents, there's no point having special Indigenous road safety campaigns. It's really about where you live. But for bicycle and pedestrian injuries, there are very targeted things that one can do. Cataract, I'll just touch on quickly. Aboriginal people have higher rates of cataract, but they have considerably lower rates of cataract surgery. Again, we tried to unpack this, looking at how does socioeconomic status contribute, how does remoteness contribute, and this is again one where you get slightly not expected result, where the disparity was greatest in the less disadvantaged areas, so the richer areas, and disparity greatest in more urban areas rather than rural areas. And there's certain parts of the state, again, when you map it, where Aboriginal people are really getting higher rates of cataract surgery, which is what they should be getting. Can't go into it in detail, but the underlying issue there is private health insurance. Very few Aboriginal people have private health insurance. Almost all cataract surgery is done in the private sector. And that's why those apparently paradoxical disparities are there. The urban areas have lots of private hospitals. The richer areas have private hospitals. And so those where the disparities are occurring. Aboriginal people who live in those areas just don't get access to cataract surgery, while in many of the regional areas they're actually providing fly-in special services, which have much greater access for people who are from poorer backgrounds. So finally, seeding success, the extreme data linkage. This includes almost 200,000 children who were born in New South Wales and who started school in either 2009 or 2012. Every 3 years in Australia we have a thing called the Australian Early Development Census, and so this study has been constructed around those two early development census points in 2019 and 2012. This only shows some of the data because we've now got 13 different data sets linked for all of these children. So we have mental health context, hospital admissions for parents, child's birth records, hospital emergency department, community services, mental health, and early childhood development. We've also got child protection data in there now, and we're moving on to get NAPLAN, which is later, we've done several times during primary school and high school educational attainment data. So it really links in nicely with some of the stuff Tammy was talking about. So the Australian Early Development Census, as I said, every 3 years, collects information across these 5 domains. It's teacher-reported information, which again probably has some relevance based on Tammy's discussion earlier that teachers may be somewhat biased in the way they report results for certain children. But nonetheless, it's a great resource and it's national. So this work we've done a lot of work again with the cohort, but this is trying to look at developmental vulnerability at age 5 according to maternal age at childbirth. Of course, there's a great interest in young mums, teenage mums, but this work has actually shed light at the other end of the mum spectrum, the older mums, where you really do need some large numbers to look at that. This just shows births, the proportion of births by maternal age and Aboriginality. And so the big issue here is that the Aboriginal mums do tend to be younger. There are many who are teenage mums or having their baby in their early 20s compared to the non-Aboriginal population. And then we could look at that risk of vulnerability on one or more of those 5 domains. Vulnerability is being in the bottom 10% on any of those 5 domains. And you can see here vulnerability is definitely highest. These are for the non-Aboriginal children, in the children of the very young mums, but that interesting kick up at the end. And this work, not for its inequalities investigation, but for that finding, has actually received a lot of attention because previous work suggested that everything was better about older mums in terms of the children's outcomes. This is showing a slightly different picture. Then here's the Aboriginal kids. You know, across the full range of maternal age, they are much more likely to be developmentally vulnerable. But this gap actually seems to increase with maternal age. Then we can also again try to unpack it by looking at, is it demographic characteristics or do these modifiable early childhood exposures play a role? Don't have time to go into it in detail, but this is the sort of absolute inequality. And we've just got one that's adjusted for child's age and sex, one showing this socio-demographic characteristics, and this is the risk difference between Aboriginal and non-Aboriginal. Once we adjust for SES, which includes area-based SES, not individual-based, we can see we're reducing that risk difference. Once we adjust for antenatal care, smoking and preschool, and this is individual level preschool attendance, again, we bring it down somewhat. So some of those modifiable things are contributing. So summary of findings from that study so far. Aboriginal babies are born to younger mothers. Children born to young mothers do have high risk regardless of Aboriginality, but Aboriginal children have higher risk across the full range of maternal age, and that absolute inequality increases. And some of those socio-demographic characteristics and modifiable exposures do account for the inequality, but not fully, but we don't measure them perfectly in the data that we have. So my conclusions: whole of population data, which is really what we're talking about today, linked routinely, have unique power to explore health disparities, and we think a useful approach is to try to unpack the contributions of these factors, because that's how you can use this essentially descriptive information to actually target interventions. It's really essential, particularly in places like Australia, that geography is actually taken into account in studies of health disparities. I think that would apply in New Zealand also. And finally, the simplest of data linkages actually hugely increases the value of these routinely collected data.